50% of health care spending in the U.S. can be traced to just 5% of the population. Those are the sickest and often poorest Americans who spend much of their time cycling in and out of costly emergency care. While congressional leaders square off toward a vote next week on the future of the health care law, there are pilot projects on the ground that are focused on how to improve treating this group of patients and also to save money. That is even the case in remote areas. Special correspondent Jackie Judd has our report from Kalispell, Montana.
Come on, girl.
Not so long ago, Shiran Green and her beloved dog were living in a car in downtown Kalispell, Montana, and routinely heading to the local emergency room because of chronic lung disease and the need for an electrical outlet.
I was there like clockwork every day, sometimes being treated, sometimes having to charge up my oxygen machine, which I used because I had no electricity. Sometimes just getting out of the cold.
It is this cycle of patients going in and out of the hospital at great cost with not much benefit that the group around this table is trying to break.
How can we avoid some of these emergency room visits that really are not necessary? These are
a pilot program funded by the federal government and a foundation began late last year in Kalispell, Billings, and Helena.
How are you?
Tired.
Healthcare players already in the community now team up in a very deliberate way to identify high-needs patients and to go well beyond the traditional bounds of medical care.
Do you think you can find housing that'll take your Section 8 voucher?
Oh, yeah.
Okay.
Laura Shadwick directs the Montana program.
Some of the themes really rest on social determinants of health. Lack of transportation, housing insecurity, food insecurity, economics, finances. Those are really some of the drivers that are the commonalities for these patients.
The Kalispell Care Team runs lean. There are community health workers like Jane Emmert who are trained to manage non-medical issues, and the head of the team, registered nurse Leslie Starling. Together, they aim to reset the paths these patients are on.
They're so sick, they've gotten so used to the way that they live. I do feel like patients get very used to their environment. They get very used to their choices. They get very used to their lifestyle, and it's almost like they build up an immunity to what their life looks like.
David Dixon was once a member of an emergency medical team and a fishing and hunting guide. Since a disabling motorcycle accident, he struggles with chronic pain and nausea, overuse of medications, and episodes of depression and anxiety. In a 14-month period, Dixon went to the ER 42 times.
I just want to have a better life. I want to be able to wake up in the morning and have a halfway decent day. I'd like to be able to make plans for tomorrow morning.
Is it hurting right now, or?
Yes.
Yeah.
In just a few weeks, the team has helped Dixon reconnect with a pain specialist and link him up to a pharmacist to sort out the many medications he is on.
Are you taking that one also pretty regularly?
There's so many medicines I'm taking that I don't know which ones are really helping and which ones aren't at this point.
Okay.
Dixon, like so many high-needs patients, has mental health issues. Specialists in Kalispell are in short supply, so Starling typically gets advice from an expert some distance away about how best to work with patients.
It sounds like you've been using a lot of those, some of the motivational interviewing skills that we've been talking about, finding what kind of barriers there are for him, finding what his goals are.
Sometimes a patient's need is as basic as a roof over one's head. The team found Shiran Green an affordable apartment, which is no easy task in Kalispell. Starling acts as a liaison to Green's primary care doctor, and other community workers literally deliver Green to Dr. Jonathan Anderson's door.
Good.
So do I have a heart?
It's still beating. She's allowing people into her life is what she's doing. Before, it was basically the ER in the hospital, and then she'd come in for follow-up visits here, and then she'd bounce around and come back. Now she's allowing people from the community to come in and allow them to help, either help her move things, allow them to kind of check in on her and make sure she's doing all right.
When Green was homeless, in one 6-month period, her Medicare charges were $100,000. Since November, hospital charges are less than $6,000. By the time this pilot program ends, the hope is over $2 million will be saved. Programs like these came first to urban areas. Rolling one out in a vast rural state like Montana is a very different kind of experiment with very unique challenges, starting with simple geography.
Sometimes we're going on mountainous roads that are icy and treacherous. Sometimes they're narrow dirt roads that you aren't sure that you want to go down.
To get to a patient can be a 60-mile round trip. So Emmert frequently heads out on her own to their homes.
What's your puppy's name?
Bailey.
As she did on this day, to visit 25-year-old Mackenzie Kramer,
I brought you a disability application.
who is slowly recovering from major surgery.
So if you try to do any of this and it's tough for you, just know that we'd be glad to help you fill it out.
Emmert is there to help him manage the paperwork for disability and to put him in touch with Starling, who can check up on many more patients if she stays behind in her Kalispell office.
How has pain been?
It's been manageable. It's getting better, I think.
The team also gently pushes Kramer to think about his future once his health stabilizes.
He's got to have something to look forward to. So that's why we're looking into possibilities with college or a job, that he could reclaim the life of a 25-year-old again. Part of the goal is to help you connect to things you might not have already.
Somebody that knows where to go, how to do it, you know.
You have a whole team of people,
I
right?
have a whole team of people.
Yes.
Progress with these patients can come in fits and starts, less than 24 hours after a home visit filled with encouragement to manage his illness differently. David Dixon takes himself back to the ER.
What happened?
I woke up nauseous and vomiting and took my medicines and couldn't keep my medicines down, so I went for a trip to the hospital again.
Dixon's team was not surprised that he went to the hospital. His visit a reminder of how fragile these patients are and how much work it takes to break the cycle.
It's taken years to get me to where I am. They're starting to understand it. They're starting to get programs together that fill in the gaps in the medical profession where I had problems before. They don't know everything. It's not a magic wand, but at least they're trying.
The pilot program has another year to prove these intensive interventions can succeed, and if so, whether there is the funding and the will to make them a new standard of care for the most difficult people to treat.
You ready to come in?
For the PBS NewsHour, this is Jackie Judd in Kalispell, Montana.
Come on, let's go inside.
Two quick notes about Jackie's story. It is not yet clear whether the moves by the president and Republicans to replace the Affordable Care Act will affect the funding of programs like this one. And for the record, the Robert Wood Johnson Foundation, which helps to fund the Kalispell pilot program, is also a funder of the NewsHour.